Hemorrhoidal disease, state of art and guidelines, stable-assisted procedures. Learning objectives. We need to understand different classifications of hemorrhoidal disease, as to consider guidelines for technique selection, is to understand potential causes of recurrence or residual disease, and to learn tips and tricks for the avoidance of undesirable outcomes. Recent guidelines published on literature. In the top, the American Society of Colon and Rectal Surgeons Clinical Practical Guidelines for the Management of Hemorrhoids, published on disease of the colorectum in 2018. In the bottom, guidelines for the treatment of hemorrhoids, published in 2016 by French Society of Coloproctology. In the middle, European Society of Coloproctology Guideline for Hemorrhoidal Disease, published in 2020. Grade of recommendation, starting from 1A, strong recommendation, and in the bottom 2C is weak recommendation, based on level of evidence and grade of recommendation. Looking to hemorrhoids and literature, what's the problem? There's a lot of variability of clinical and anatomical presentations included in the category of hemorrhoidal disease. All publications try to demonstrate superiority of one technique over another without considering the great heterogeneity of the analyzed groups, which are selected using only the Golger classification. Golger classification of hemorrhoids is the most important classification present in the literature, but you can see there are some limitations because the 4-degree, from first degree, no prolapse and prominent hemorrhoidal vessels, second degree, prolapse and valsalva with spontaneous reduction, third degree with a manual reduction, and fourth degree with a manual reduction ineffective or impossible. You can see that the second and the third degree are an amnestic report, and manual reduction often is more related to the patient, and no mention in the classification of prolapse dimension or segmental or circular involvement or type and frequency of symptoms, and no mention of associated comorbidities. Nevertheless, the treatment show is not very useful with this classification, but Golger classification is widely used. Starting with the American Society of Colon and Rectal Surgeons, Clinical Practical Guidelines for the Management of Hemorrhoids, it's published on disease of the colorectum in 2018, start with medical treatment. Grade of recommendation 1B, adequate fluid and fiber intake. This is the first line therapy for patients with symptomatic hemorrhoid disease. And medical therapy also can be offered grade 2B, and office treatment grade 1A, bending, hemorrhoidal bending is the most popular and effective in this patient. So hemorrhoidectomy should typically be offered to patients with symptoms results from external hemorrhoids or combined internal and external hemorrhoids with prolapse, grade 3 and 4 of the Golger classification, the grade of recommendation 1A. Stapled hemorrhoidopexy show less pain and faster recovery when compared with excisional hemorrhoidectomy, but with a much recurrence rate and follow-up. The French Society of Coloproctology guidelines shows the same methodology system with grades of recommendation based on the scientific level of evidence provided by the literature, with grade A, grade B, and grade C. In the paper, office treatment in cases of bleeding due to grade 1 and 2 hemorrhoids was reported, and with a level 1 grade A. Hemorrhoidectomy, also in the level 1 grade A, was the first line treatment in cases with acute complication, severe anemia, and stage 4 hemorrhoids, and for all hemorrhoids in 2 and 3rd degree of Golgi classification. Stable hemorrhoidopexy was indicated in cases of grade 2 and 3 hemorrhoids with a level 1 grade A of evidence. Better postoperative tolerance, shorter hospital stay, and faster resumption of normal activities when compared with standard hemorrhoidectomy, but less effective than hemorrhoidectomy with a 3 to 5 times more frequent rate of recurrence or prolapse. As I mentioned, also for Doppel-guided hemorrhoidal artery ligation, DG hole with or without mucopexy, recommended in cases of grade 2 and 3 hemorrhoids, less effective than hemorrhoidectomy, and alternative to hemorrhoidopexy. Finally, the European Society of Coloproctology guideline for hemorrhoidal disease published on colorectal disease in 2020. Looking inside, we can see that Doppel-guided hemorrhoidal artery ligation could be used in patients with grade 2 and 3 hemorrhoids, and also the same for stable hemorrhoidopexy. Hemorrhoidectomy could be used in patients with grade 2 and 3 hemorrhoids and should be used in patients while refractory to outpatients procedure, the moderate level of evidence. Here is the algorithm in the European Society of Coloproctology guideline. You can see surgery is in the grade 3 and 4. In the operation indicated was hemorrhoidectomy, and in alternative, stable hemorrhoidopexy and Doppel-guided hemorrhoidal artery ligation with or without mucopexy. A focus on recurrence, evaluation where possible with self-assessment hemorrhoidal score system or with a coloproctological examination, and also about recurrence, we have to demonstrate if the disease is recurrent or residual, so present in the first postoperative period. This is a paper from Watson, published on Lancet 2016, was one of the most important paper with a pragmatic multicenter randomized controlled trials. And if you look inside, you can see that recurrence evaluation were made with a self-assessment score, but with some weakness point. For example, looking to the score, everyday soiling and itch, you can reach hemorrhoidal score 8, and the same score with everyday bleeding and pain, so same score value, different patient. And some focus on the type of anopexy, we see that the anopexy operation resulted in a complete donut in the specimen in the 88%. So 12% of patients had a complete donut. And the final staple line was situated between 2 and 3 centimeters above the dental line in 7-6%. So in the 24% of a patient, higher or lower stable line with an incorrect anopexy were made. Wrong technique. And looking to the type of stapler device, no high-volume stapled hemorrhoidopexy were reported. And if you look at the results in terms of recurrence, at 12 months after randomization, hemorrhoids recurred in the 32% after 1 year in the stapled group and in 14% in the traditional excisional surgery group. But after 2 years, hemorrhoids recur in 42% in the staple group and 25% in the traditional excisional surgery. So maybe an high recurrence rate also for traditional surgery not present in the practical clinic. This is due probably to the type of evaluation with a self-score that have a bias in the interpretation. Some comments on guidelines and literature. So according to the guidelines, hemorrhoidectomy shows better results instead of other techniques in the third and especially in the fourth degree of Gallagher classification. But if you analyze inside the literature, we can see that patients are evaluated for recurrence according to self-assessment score and not with a complete clinical examination. And if you look at 24 months follow-up, 45% of recurrence with a stapled hemorrhoidopexy and 25% with hemorrhoidectomy are much higher than normal clinical experience. And skin tags are referred as a recurrence by patients instead of residual disease. If you analyze guidelines and literature, you can see that stapling technique in the literature used for guidelines is only referred to normal device. No mention of high-volume stapler device. And if you look inside the group with the anopexy, we can see that 24% of incorrect anopexy to high or too low staple line and 12% incomplete donut in the resected tissue with the consequent incorrect technique. But if you look to the results, there was the same, they were considered the same and not excluded. And high volume stapled hemorrhoidopexy allows to remove more prolapsed tissue better than normal device and shows better results in the third degree instead of 4, may be related to fixed anoderma or skin tags. So tips and tricks are important to avoid undesirable results and to realize a correct procedure. Tailored surgery in the coloproctological field is mandatory.